Let's move into our next segment, which is sequencing therapies. And so, Wallace, I'm going to start with you with this question: is how do you monitor response to treatment and disease worsening?
So we routinely monitor both clinically and with MRI. So the clinical measures that we're most interested in are relapse rates and disability. And of course, there's different ways of measuring disability. The way that's most established is to measure the EDSS score, which is largely derived from the results of the neurological examination and walking the patient, although increasingly we're integrating into our clinical practice other measures of disability, including timed walk tests for lower limb function, 9-hole peg tests for upper limb function and dexterity, and measures of cognitive impairment like the SDMT, which I think is fairly easy to integrate into clinical practice. In terms of MRI monitoring, at least at our centre, we undertake at least annual MRI follow-up. We mainly focus on following the brain MRI. We're tending to use less and less gadolinium in our centre, mainly because we've sorted out MRI protocols and patients are now all receiving a 3D FLAIR scan, which facilitates new lesion detection very easily without the use of gadolinium. And so after arranging a re-baseline MRI, say 3 to 6 months after starting on a therapy, we'll then do regular MRI scans to measure response in terms of looking for new T2 lesions.
Okay, and Sven, taking into consideration what we can measure, which is Wallace has nicely outlined, how do you make the determination as to when you need to switch?
Yeah. This is always based on a very individual decision. So following this concept of patient empowerment, we normally try to discuss all the decisions together with the patients, and we try to make a jointly decision. My opinion is that the decisions largely focus on efficacy of a drug. So in this efficacy is not, or the treatment effect concerning efficacy is normally driven by relapses, because this is easy to count and along the guidelines. I think it's somehow supported by EDSS progression and also maybe by new lesions. However, all the additional measures, which are, in my opinion, very useful. Wallace mentioned the SDMT, which is important concerning cognition. Atrophy scores in the MRI might be important. However, the treatment decisions are still based mainly on relapse activity and new lesions. And there's also, let's say, maybe an interesting note, this was also reported in a paper, that the patients are much more engaged earlier in treatment decisions. But if it's then not working, the physician is more and more taking over, because obviously he or she feels to be, more informed compared to the patient. So we start with a joint decision, but sooner or later the physician takes over in a way.
Patricia, how do you figure it out?
Yeah, so I think there are various reasons why you might switch therapy. Breakthrough disease activity and the AAN 2018 guidelines said a year on treatment, if there's one or more clinical attacks worsening on the exam or 2 or more MRI lesions, it should trigger a discussion about switching. Adverse events, intolerable adverse events. With multiple options, a patient should not be forced to stay on a treatment that they're miserable on and hate. A treatment that led to a laboratory disturbing abnormality in liver enzymes or white blood cell count or lymphopenia would be a fair reason. And neutralizing antibodies that were persistent in the case of natalizumab obviously would indicate it should be switched. And a changed risk-benefit ratio that was now unacceptable to the patient and the physician would also be a reason to really talk about switching. So there are really multiple reasons that one might switch.
So I agree with all those comments. I think one area of uncertainty as to what to do with patients who are progressing on a therapy. So in people who say are taking a medication and they're not experiencing relapses and their MRI is stable, but their EDSS is worsening, I think we're lacking evidence about how best to manage those patients. And that's something that really does need to be addressed going forward.
So you highlight an important issue, and that is the near absence of decent evidence on defining inadequate treatment response. Side effect profile is easy, but inadequate treatment approach is something we just haven't done yet. And so it becomes, as Sven started out saying, a very individual thing. But it is a conversation with you and the patient. It is interesting what Sven points out, that patients become engrossed or embedded in their own therapy and actually become a little more resistant over time to switching than they would be earlier on. I think that's an interesting observation. But we really need data. And unfortunately, it looks like the data is going to be agent specific, because what little data we have that came out of the Barcelona group suggested that the indicators of an inadequate response to interferon didn't necessarily hold up to be inadequate responses for glutarin or acetine. But it's certainly an area that we need to explore and develop better guidelines for, because our patients need it, our economics need it, and we need to figure out how to do that.